Hello everyone, this is Dr. Surbhi and this is the second part of the introductory lecture on diabetes mellitus. In this part, we'll be discussing the pathogenesis of diabetes. So first starting with the pathogenesis of type 1 diabetes. It is an interplay of genetic, environmental and immunologic factors which lead to an immune mediated destruction of beta cells. This destruction leads to an insulin deficiency. Now, type 1 diabetes, it can present at any age, but most commonly it occurs in less than 20 years. Earlier, it was considered that type 1 diabetes usually occur in only less than 30 years of age and more so in less than 20 years. But now it has been discovered that 5 to 10% of the patients, they develop the autoimmunity at more than 30 years of age. Now, type 1 diabetes, it includes the islet-directed autoimmunity, which is usually triggered by an infectious or environmental stimulus. So after this triggering event, there occurs beta cell destruction and progressive loss of insulin. But this progressive loss of insulin occurs, most patients, they do not present. Till the loss of beta cell is up to 70 to 80%, then only the patients will present with diabetes. So the loss of beta cell mass at time of presentation is as high as 70 to 80%. Now, after the initial clinical presentation of type 1 diabetes, a honeymoon phase may ensue, during which the glycemic control is achieved with modest doses of insulin, or rarely insulin is not needed. However, this is only a fleeting phase. It will be there only for a little duration of time. This fleeting phase of endogenous insulin production from the residual beta cell disappears after some time, and then progressively the patients, they become insulin deficient. So honeymoon phase is that phase in which the residual beta cells, they produce insulin, and the patients in that phase do not require insulin much in type 1 diabetes. So the glycemic control can be achieved with modest doses of insulin. But later the residual beta cells, they also disappear, and there is an absolute insulin deficiency that is occurring. So as we can say that the individuals with a genetic predisposition, they are exposed to a trigger. The patients with a genetic predisposition, they are exposed to a trigger at a certain point that initiates the autoimmune process of beta cell destruction. Now, stage one is characterized by the development of 2 or more islet antibodies, but there is no maintenance of a normoglycemia, that is, the blood glucose levels are normal. But stage 2 is then it is the continued autoimmunity and progressive development of dysglycemia. Okay, so stage 1 is autoimmunity, but the patient is euglycemic. Stage 2, however, the patient becomes dysglycemic. The stage 3 is the stage of overt diabetes, that is characterized by the development of hyperglycemia that exceeds the diagnostic criteria of diabetes. So this shows the downward slope of beta cell function, and it varies between individuals, and it may not be continuous in all the individuals. So this phase of stage 2 is usually the first 1-2 years of the onset of diabetes. So first 1 to 2 years of onset of diabetes is the honeymoon phase of diabetes, when there is residual beta cells. The residual beta cells, they produce some amount of insulin which is sufficient to carry out euglycemia, and therefore they require modest doses, or they do not require insulin at all. But after 1 to 2 years, these residual beta cells also get destroyed, and there is an absolute insulin deficiency that occurs. So pancreatic islets as we see the pathology, there will be infiltration of the lymphocytes, leading to insulinitis, beta cells destroyed, and islets become atrophic. Here I will just stop to tell you one important point which I'll be revising again. I have done that in the previous lecture as well, that there are 4 types of cells in the pancreas: the alpha cells that produce glucagon, beta cells, they produce both insulin and islet amyloid polypeptide. The delta cells, they produce somatostatin, while the PP cells, they produce pancreatic polypeptide. Now we'll be discussing the genetic factors that are responsible for type 1 diabetes. Remember, type 1 diabetes, it is less genetic. Okay, so concordance in identical twins is 40 to 60% only, therefore it is less likely to be inherited. Type 1 diabetes is less likely to be inherited. On the contrary, type 2 diabetes, it is more likely to be inherited. Okay, so in type 1 diabetes, more of other factors are responsible, like environmental or immunologic or infection, etc. They are responsible for the pathogenesis of type 1 diabetes and not the genetics. But like 40 to 60% are inherited, we have to study the genes which are responsible for type 1 diabetes, genes which are responsible or are mutated in type 1 diabetes. So on chromosome 6, the HLA region or the MHC2 region, is the major susceptibility gene for type 1 diabetes. And also polymorphisms all in the HLA region are responsible for 40 to 50% of the patients of type 1 diabetes, right? So the mutations in chromosome 6 HLA region are the main susceptibility gene responsible for type 1, and polymorphisms are present in 50% of the patients of type 1 diabetes. The HLA haplotypes which are responsible for type 1 are the DR3 and DR4. Association of HLA haplotypes with type 1 are HLA DR3 and DR4. Okay, so in addition to MHC2 complex, there are 20 other loci which you can remember if you want, like CTLA4, IL2, PTPN22, etc. Now, because there is a very low risk of inheritance of type 1 diabetes, so if one parent is positive for type 1 DM, the risk of diabetes development in the patient or in the son or daughter is only 3 to 5%. So if one of the parent is diabetic, then the chance of inheritance to the offspring is 3 to 5%. But if the sibling is diabetic, then the chance is 5 to 15%. Okay, so 75% of the patients in type 1 diabetes, they do not have first degree relative with insulin. They do not have first degree relative with risk of type 1 diabetes. Okay, so inheritance is very low. Next, we'll be discussing the immunological markers or the immunological association of type 1 diabetes. So this is the main thing that is responsible for the destruction of beta cells, that is the islet cell antibodies. The islet cell antibodies are mainly directed against glutamic acid decarboxylase 65 molecule or against insulin, or these are insulin autoantibodies type 2 or zinc T8 antibodies. Okay, so the insulin and glutamic acid decarboxylase 65 insulin autoantibodies and glutamic acid decarboxylase autoantibodies and insulin directed autoantibodies are the most common among them. So islet cell autoantibodies, they're positive in more than 85% of individuals at the time of diagnosis with type 1 DM. Also, these islet cell autoantibodies can be found in other types of diabetes, like in type 2 DM, they are positive in 5 to 10% of the patients, while in gestational diabetes, they are positive in less than 5% of the patients. So, more than 85% of the patients with type 1 DM at the time of presentation will be positive for islet cell autoantibodies. 5 to 10% of the patients with type 2 DM will be positive for islet cell autoantibodies, while less than 5% of patients will be positive for islet cell autoantibodies if they have gestational diabetes mellitus. Okay, these were the immunologic factors. This is very important to learn. The islet cell autoantibodies, they are directed against glutamic acid decarboxylase. Glutamic acid decarboxylase, this is the most important antibody against which the antibodies, this is the most important molecule against which the autoantibodies are directed against. The other being the insulin autoantibodies type 2 and the insulin antibodies. Now, next we'll discuss the environmental factors which could be responsible as or can be the triggering agents for type 1 diabetes. These include viruses like Coxsackie, rubella, and enterovirus. They can be bovine milk protein, nitrosuria compounds, and vitamin D deficiency. This is all to learn in the pathogenesis of type 1 diabetes. Now, next we'll discuss the pathogenesis of type 2 diabetes. So type 2 diabetes, it includes both insulin resistance and abnormal insulin secretion. Both are required to develop type 2 diabetes. Okay, so insulin resistance is the one that usually precedes, then further leading to abnormal insulin secretion. There's usually insulin resistance leading to hyperglycemia leading to glucotoxicity and increased lipid production, also the lipotoxicity of the pancreatic beta cells, and then this leading to further this beta cell destruction, and thus leading, and also there is amyloid deposition in the beta cells that further leads to destruction of the beta cells and thus leading to insulin deficiency. So type 2 diabetes starts with just insulin resistance, and then later on develops abnormal insulin secretion as well, leading to insulin deficiency. So there are certain differences in the type 2 diabetes that occurs in the Latinos and as compared to the East Asians and South Asians. So Latinos, they are more insulin resistant, while the East and South Asians, they have more of beta cell dysfunction. That is, they have decreased insulin secretion. The Latinos, they develop the type 2 diabetes at an older age. Okay, they develop type 2 diabetes at older age, while the East and South Asians, they develop the type 2 diabetes at a younger age. Latinos, they have a higher BMI as compared to the South and East Asians, which have a lower BMI. Okay, that is, the Latinos, they are usually obese, while the East and South Asians, they may or may not be obese. They usually have a lower BMI. Now, type 2 diabetes people, they can also be divided into those who are ketosis prone as well, and secondly, they are ketosis resistant. So, ketosis prone, that is more of diabetic ketoacidosis developing, although diabetic ketoacidosis is mainly a complication of type 1 diabetes. It may occur in some patients of type 2 diabetes as well. So, some patients of type 2 diabetes are ketosis prone, and these are the ones that are mostly obese patients, right? While the lean patients with type 2 diabetes, they are ketosis resistant. They do not have chances of development of diabetic ketoacidosis, right? Now, next we'll study the genetic factors that are responsible for type 2 diabetes. Remember, type 2 diabetes, it has a strong genetic component, with the concordance in identical twins being as high as 70 to 90%. That is, they are more likely to be inherited. They have a strong genetic component. If one parent has type 2 DM, the risk increases. But if both parents have diabetes, then the risk increases to as high as 40%. The individual, if the one parent is diabetic, then the risk increases by around 10 to 20%. But if both parents have diabetes, then the risk approaches around 40%. Risk of inheritance of diabetes approaches 40%. Now, the insulin resistance. Insulin resistance is the first stage in the development, that is the pre-diabetic stage, is positive in non-diabetic individuals, first degree relatives, in a high proportionate. Okay, so in crux, the type 2 diabetes it has a strong genetic inheritance. It has a around 40% chance of being inherited if both parents are diabetic. Now, the genetic, talking about the genes, type 2 diabetes is usually polygenic in nature. Most prominent of the genes being the transcription factor 7 gene, like transcription factor like 2-7 gene. Okay, so transcription factor 7 you can remember. The other genetic polymorphisms can include peroxisome proliferator activator receptor gamma defect, or can be the invert rectifying potassium channel defect, zinc transporter defect, insulin receptor substrate defect, or calpain 10 defect. These are the various genes in which the polymorphisms can occur in type 2 diabetes. So this was the genetics of type 2 diabetes. Next, discussing the pathophysiology, that is the pathology, how we see what all changes we see pathologically in type 2 diabetes. So there is insulin resistance, impaired insulin secretion. Also, there is excessive hepatic glucose production in type 2 diabetes, and abnormal fat metabolism and low-grade systemic inflammation that is accompanying type 2 diabetes. We have discussed that insulin resistance is present, impaired insulin secretion is present, but these three things also present, that is excessive hepatic glucose production, there is increased gluconeogenesis and increased glycogenolysis in the liver. There is abnormal fat metabolism in the adipose tissue, and there is low-grade inflammation because of the presence of IL-6 and TNF alpha being produced in excess because of the insulin resistance. Okay, now remember that more than 80% of the patients with type 2 DM, they are obese. That is, they have an increased hip to waist ratio, that is mainly they have a central obesity present. Okay, so more than 80% of patients with type 2 diabetes, they are obese. So to summarize the pathophysiology of type 2 diabetes, there is an insulin resistance that is pre-existing in type 2 diabetes. Because of the insulin resistance, the pancreas, it tries to overcome the resistance by secreting more and more of insulin. That leads to a compensatory hyperinsulinemia. But over this time, this insulin is not sufficient to control the glucose levels. That leads to an impaired glucose tolerance that is manifested in the form of an increased postprandial glucose. Over time, there is progressive decline in the insulin secretion because of the increased glucotoxicity and lipotoxicity that is occurring in diabetes. Plus, also there is also increase in the hepatic glucose production that occurs in diabetes. So, because of the insulin resistance, there are various metabolic effects occurring in the various organs of the body. There is changes in the brain, like decrease in the cognitive function and mood disorders. While because of the various adiponectins which are imbalanced in diabetes, the hormones like the adiponectin and leptin, which suppress the appetite, they are decreased while the resistance is increased. Resistant adipokine is increased while adiponectin and leptin, they are decreased. So appetite is not suppressed, and overall appetite, it increases because of the release of these appetite stimulants. Okay, Also, there is decrease in the gonadotropin release in insulin resistance and leading to hypothalamic hypogonadism. Insulin resistance also confers a decreased brown fat activity. You have to know that brown fat is mainly thermogenic in the body, helps in producing heat. Because there is decreased brown fat activity, heat production is impaired, thus leading to hypothermia in the body. Also, there is an overall decrease in the white cell mass. Also, there is increased hepatic glucose production which occurs. So these were the various metabolic effects of insulin resistance over the body. Insulin resistance and the type 2 diabetes, because it leads to a chronic hyperinsulinemic state earlier, there is an increase in the insulin degrading enzymes as well. Hyperinsulinemia leads to increased production of enzymes that will degrade the insulin. So increase in the insulin degrading enzymes. These insulin degrading enzymes, they also lead to increased amyloid degradation, leading to formation of neurofibrillary tangles. So the initial P53 PGSK3B beta, that is glucose synthase kinase 3 beta activity is decreased in the brain. This will lead to increased tau protein phosphorylation. Increased tau phosphorylation will lead to increased tau protein deposition and increased amyloid deposition. This amyloid through the insulin degrading enzymes will be converted to the neurofibrillary tangles. Thus, there is an increased risk of Alzheimer's disease in type 2 diabetes. Also, in type 2 diabetes, because of the insulin resistance, there is a mitochondrial dysfunction that occurs that impairs the neuronal function and leading to cognitive and mood disorders. Also, activity of various channels and pathways like SRE, BP, and altered channel activity of NMDA and AMPA, etc., will lead to altered neuronal function and cognitive and mood disorders occurring in type 2 diabetes. Also, because of a decreased cholesterol metabolism that occurs in type 2 diabetes, there will be an impairment of synapse formation. There will be an impairment of synapse formation. There will be an decreased neuronal firing thereafter. So because the synapses are responsible for neuronal firing, therefore the nerve velocity will decrease, the nerve conduction will be altered, there will be decreased neuronal firing, and overall leading to cognitive and behavioral disorders. So cognitive plus behavioral disorders, they occur in diabetes as because of the above things. Now, as we had discussed in the earlier video on the introduction to diabetes, here we are discussing that adipose tissue, it releases various adipokines, which are responsible for the maintenance of weight regulation, and that is weight regulation, maintenance of weight, and secondly, they're also responsible for suppressing appetite. So, adiponectin APN and leptin are the two hormones that are responsible for suppression of the appetite, and they also decrease the glucose production and improve insulin resistance. Adiponectin and leptin, they are responsible for inhibition of gluconeogenesis in the liver and promote and also promote or they decrease glycogenolysis, while the resistin, it causes inhibition of insulin signaling, and insulin signaling is inhibited in resistin, and it promotes gluconeogenesis, it promotes glycogenolysis. While because of the increase in IL-6 and TNF alpha that is secreted from the adipose tissue in type 2 DM, there is inhibition of the insulin signaling, therefore increased insulin resistance occurs in presence of inflammatory cytokines IL-6 and TNF alpha that increase in type 2 diabetes. So these are the factors which are responsible for increased insulin resistance contributed through the adipokines. Now, at the onset of diabetes, the beta cell function has already decreased to around 50%. That is, only 50% of the beta cells, they are functional at the diagnosis of type 2 diabetes. And over the progression, due to the chronic glucotoxicity and lipotoxicity, there is progressive decline in the beta cell mass and progressive decline in the beta cell function, thus leading to a progressive decline in the insulin secretion. Thus, over time, that is in the later stages of diabetes, the patients may require insulin. Some they usually require insulin at a later stage. Some, they have a destruction of that occurs at a very quick pace, therefore may require insulin even a few years hence the diagnosis of diabetes. Also, the beta cells, they generate islet amyloid polypeptide or amylin that is responsible for formation of amyloid fibrillary deposits in the pancreas, also responsible for the overall decrease in the beta cell mass. So, four factors are there that contribute to the islet dysfunction. One is a chronic hyperglycemia that leads to glucotoxicity, increased free fatty acids that lead to lipotoxicity, increased IL-6 and TNF alpha, as we have discussed. These are pro-inflammatory cytokines that decrease the insulin signaling. And last is the decrease in the GLP-1 that occurs in cases of type 2 diabetes. So these are the four factors that leads to islet dysfunction in type 2 diabetes and thus leading to decreased insulin secretion in type 2 diabetes. Now we'll be discussing the various insulin resistance syndromes, of which diabetes is only one of the component. So insulin resistance is a cause of type 2 diabetes and it is only one of the components of insulin resistance syndromes. It is a spectrum of disorders which include many things. So to classify the insulin resistance, it is of two types. It is of type 2 types. One is type A and one is type B. So in type A, it is characterized by three things, that is severe hyperinsulinemia that will always be present with obesity and hyperandrogenism. While in type B, there is severe hyperinsulinemia with hyperandrogenism and presence of autoimmune disorders. So type A usually occur in young women, while type B, they occur in middle-aged women or men. Okay. Now type A is usually unidentified, its cause is unidentified, while type B, there is antibodies against the insulin receptor. So in type A, it does not have autoimmune process and the cause is unidentified, while in type B there are antibodies against the insulin receptor. Okay. So the first spectrum is the metabolic syndrome or the insulin resistance syndrome or syndrome X. The ATP3 identified 6 components of metabolic syndrome that increases the risk of development of type 2 diabetes and the cardiovascular disorders. The 6 components include: number 1, the insulin resistance; number 2, abdominal obesity; number 3, atherogenic dyslipidemia; number 4, raised BP; and number 5, a pro-inflammatory state; and number 6, a pro-thrombotic state. These are the various components of metabolic syndrome, and due to the presence of these components, there is increased risk of type 2 diabetes and increased risk of development of cardiovascular disease. So the National Cholesterol Education Program (NCEP) Adult Treatment Panel 3 has given a harmonizing definition criteria for metabolic syndrome diagnosis. So it includes three or more of the following criteria. Number 1 is presence of central obesity. Central obesity is measured by the waist circumference, which has been described as different according to the different ethnicity. Now, second criteria is the presence of hypertriglyceridemia. Hypertriglyceridemia, that is increase in the triglyceride levels to more than 150 milligrams per deciliter. Number 3 includes a low HDL cholesterol of less than 40 milligram per deciliter in cases of men, while less than 50 milligrams per deciliter in cases of females. Number 4 is the presence of hypertension, that is a BP of more than 130 systolic, more than equivalent to 130 systolic, and more than equivalent to 85 diastolic. And number 5 is the fasting plasma glucose level of more than 100 milligrams per deciliter, that is presence of impaired fasting glucose, or if there is a specific medication that the patient has been prescribed, or there is a previously diagnosed type 2 diabetes. So these are the criteria. Three out of the at least 3 out of the 5 criteria should be fulfilled for classifying the patient to have metabolic syndrome. So in South Asians or the Indians, we use more than 90 centimeters of waist circumference and more than 80 centimeters of waist circumference in men and women respectively. Okay. Now, other syndromes which can also be associated with insulin resistance as the polycystic ovarian syndrome, which are very common in women, causing menstrual irregularities and presence of various signs of insulin resistance like Ketosis nigricans, etc. There are also various lipodystrophies which are the selective loss of adipose, in which selective loss of adipose tissue occur, which also incorporate insulin resistance as a major part of it. So these were the various insulin resistance syndromes, and now we'll be discussing about the prevention of type 2 diabetes. So as we already know, type 2 diabetes is preceded by an impaired fasting glucose or an impaired glucose tolerance. Therefore, the onset can be delayed if this impaired fasting glucose or impaired glucose tolerance is identified in the patient, and then we accordingly modify the lifestyle or take appropriate pharmacological measures to delay the progression of this impaired fasting glucose or impaired glucose tolerance to diabetes. So, as the studies indicate, diet combined with exercise of at least 30 minutes per day, 5 times per week, these two, a combination of these two, it delays the development of diabetes by as much as 58%. Other studies have also studied metformin for the delay of diabetes, and it has said that if the patient has an impaired fasting glucose and impaired glucose tolerance and patient takes metformin, then it can prevent or delay the development of type 2 DM by as much as 31%. So, although metformin is not used in all patients for the delay of diabetes, the ADA, American Diabetic Association, it recommends metformin if the patient has an impaired glucose tolerance, plus the age of the patient is less than 60 years with a higher risk. Second, the patient has a BMI of more than 35 kilograms per meter square. And third, the patient is a female who has a history of gestational diabetes in her previous pregnancy. So these are the indications to start metformin if the patient has impaired glucose tolerance with the following risk factors. Okay. Now, it has been said to encourage patients to have a normal BMI if they have a strong family history of type 2 DM. They should be encouraged to exercise and maintain a diet control in order to achieve a normal BMI if they have a strong family history, because type 2 DM has a strong genetic component, and combined with obesity, it poses a high risk of development to type 2 DM. Okay. Now, patients with impaired fasting glucose or impaired glucose tolerance or HbA1c in the range of 5.7 to 6.4, or impaired fasting glucose that is in the range of 100 to 125 milligrams per deciliter, or impaired glucose tolerance that is a 2-hour plasma glucose of 140 to 199 milligrams per deciliter. These three groups, they should be screened for type 2 diabetes annually. Okay, they should undergo these three measurements, that is the fasting plasma glucose, the 2-hour plasma glucose, and HbA1c annually. Okay. So this was about the prevention of type 2 DM. Now we'll study the class of monogenic diabetes in a little brief. These monogenic diabetes mellitus, these are the group which contain genetically defined diabetes caused by single gene mutations. Okay, so the we can divide the clinical subtypes of beta cell monogenic diabetes into maturity onset diabetes of young, neonatal diabetes, and diabetes with extra pancreatic features. Okay, so we can divide the beta cell monogenic diabetes into maturity onset diabetes of young, neonatal diabetes, and diabetes with extra pancreatic features. The maturity onset diabetes of young can have genetic defects in the enzyme glucokinase or can have genetic defects in the transcription factors, that is the hepatocyte nuclear transcription factor. Okay, so the defect in glucokinase is seen in MODY type 2, while MODY type 1, 3 and 5, it is associated with defect in the transcription factor. Okay. The neonatal diabetes can be divided into permanent neonatal diabetes and transient neonatal diabetes, and these diabetes, they usually have an onset less than 6 months. Okay, that is in the neonatal period. And diabetes with extra pancreatic feature, they have two types. One is the renal cyst and diabetes, renal cyst with diabetes, and second is the mitochondrial diabetes and deafness. Mitochondrial diabetes and deafness. So these are the forms of monogenic diabetes. Just discussing a little detail about the glucokinase MODY. Glucokinase MODY, they usually have a mild stable hyperglycemia. They have an onset at birth itself, and there is no significant complication that are associated with the glucokinase type MODY. While the transcription factor MODY, they usually have familial young onset diabetes. They are sensitive, that they are responding to sulfonylureas. They usually do not require insulin. Their sulfonylureas are sufficient enough to control the glycemic hyperglycemia, and but these transcription factor MODY, they are susceptible complications, contrast to that of the glucokinase MODY. So maturity onset diabetes of young, they are usually more than 10 varieties of MODY, but the most common being 1, 2, 3, 4, 5 and 6. Out of these, the most common form is the MODY 3. MODY 3 is the most common form. So MODY 1 is caused by defect in the hepatocyte nuclear transcription factor 4 alpha. MODY 2 is caused by glucokinase defect. Okay. MODY 3 is caused by defect in the hepatocyte nuclear transcription factor 1 alpha. MODY 4 is caused by the insulin promoter factor 1 defect. MODY 5 is caused by hepatocyte nuclear transcription factor 1 beta, while the MODY 6 is caused by neurod 1 defect, that is neurogenic differentiation differentiation factor type 1. Okay, so these were the defects in different types of MODY. So these transcription factors, remember the new transcription factors, the hepatocyte and the hepatocyte nuclear transcription factors, as we have already discussed, they are generated in the liver as the name suggests, but they can also be generated in the pancreatic beta cells and in the kidney. Okay. So what is the approach in saying that these patients can have monogenic diabetes or maturity onset diabetes of young? So if the patient presents with diabetes and is less than 30 years of age, we'll do a clinical assessment, that is we can measure the plasma glucose, we'll do the glutamic acid decarboxylase autoantibodies, we do the HbA1c of the patient, we also measure the C-peptide levels, and if the glucose is more than 15 millimoles, we always measure the ketones also. So if the patient has presented acutely with severe symptoms, this patient is ketones positive, or patient has diabetic ketoacidosis, and beta cell antibodies are also positive, that is glutamic acid decarboxylase antibodies or insulin autoantibodies, they are positive, then the patient is more likely to be type 1 DM. It cannot be type 2 DM, okay, or other type of DM. But the patient is not unwell, patient is good at presentation, is not ill, the ketones are negative, and the antibodies, autoantibodies, that is glutamic acid decarboxylase or insulin autoantibodies, are negative, then the patient's type 1 diabetes is ruled out, does not have autoimmunity, ruled out type 1 diabetes. Now we'll go to checking the insulin resistance. If the patient has normal BMI and there is no insulin resistance, but there is a strong family history of diabetes, that's the family history of diabetes is present, then we will check the various things. Normal BMI, no insulin resistance. No insulin resistance means type 2 DM has been ruled out. Therefore, this leaves the beta cell form. Now we will check for young onset deafness in the patients. If there is young onset deafness, that will point towards the MIDD, that is mitochondrial defect in diabetes. Mitochondrial defect with deafness and diabetes, okay, MIDD. This is the mitochondrial diabetes. We will check for mitochondrial defects. If the patient with the normal BMI, no insulin resistance, strong family history there, if the patient has mild fasting hyperglycemia, HbA1c is less than 7.5%, and the patient remains asymptomatic, as we have discussed, the mild stable hyperglycemia and no significant complications, patient asymptomatic, it will be glucokinase type of MODI. The patient with strong family history, with glycosuria, and with a CRP of less than 0.5 milligram per deciliter, but sensitive to sulfonylureas, then it will classify as the transcription factor type of MODI, that is the transcription factor MODI, that is causing mutations in the hepatocyte nuclear transcription factor, either 1 alpha or 4 alpha or 1 beta, also causing various types of MODI. If the patients with this normal BMI, strong family history, has renal cysts present, then it will classify as either the renal cyst with diabetes, RCAD, okay, or it can also occur along with hepatocyte nuclear factor 1b MODI, okay, that is the MODI type 5. Now the patients who has antibodies negative, ketones negative, but has obesity and insulin resistance positive, patient has signs of insulin resistance like acanthosis nigricans, associated hypertension and non-alcoholic fatty liver diseases there, presence of dyslipidemia is there, or there is a complex of insulin resistance syndromes associated with PCOS in the females, then it points towards the presence of type 2 diabetes. So just to summarize the approach, if the diabetes is diagnosed around less than 30 years of age, then we see if the patient can be treated with insulin or not. Okay, if the patient is insulin treated, we check whether there is presence of C-peptide. If C-peptide is negative, then it is type 1. If, however, C-peptide is positive, we check the glutamic acid decarboxylase and the insulin autoantibodies. They can be positive in type 1 diabetes, or they can also be positive in latent onset diabetes of adults. Latent autoimmune diabetes of adults. These two antibodies can be positive in type 1 or latent autoimmune diabetes of adults. If, however, these autoantibodies are negative, then and the C-peptide is positive, then we can go for genetic testing for testing all the monogenic types of diabetes. If these genetic testing is positive, we can do monogenic diabetes. If these are negative, then it can be type 2 diabetes or atypical type 1. Okay, so now we'll discuss the latent autoimmune diabetes of adult. Autoimmune diabetes of adults. It is also called type 1.5 diabetes. So there are few facts which I have to remember about these 1.5 diabetes or the latent autoimmune diabetes of adults. It looks like type 2 diabetes. It looks like type 2 diabetes. 10 to 25% of type 2 diabetes, they are actually misdiagnosed. They're actually latent autoimmune diabetes of adults, which are misdiagnosed as type 2. 10 to 25%. Second fact is that it have symptoms that are similar to type 2 diabetes, like weight loss, excessive thirst, frequent urination, and blurred vision. Third fact is that this type 1.5 diabetes is typically diagnosed in patients more than 30 years of age, just like the type 2 diabetes, which is usually in the older age group. Therefore, the type 1.5 type diabetes or the latent autoimmune diabetes of adults diagnosed in adults more than 30 years. Type 1.5 diabetes actually destroys the cells that produce insulin, like type 1. There is destruction of they usually do not require insulin initially, but later they become insulin requiring, just like type 2 diabetes. So if the patient comes who is non-insulin requiring diabetic patient, diagnosed at an age of 35 to 60 years, has a family history of type 1 diabetes or autoimmune diabetes, and a lean body mass index. This is important. How it is different from type 2 diabetes? The type 2 diabetes, more than 80% of the individuals, they are obese, while in 1.5 types diabetes, or also called as LADA, that is the latent autoimmune diabetes of adults, they have a lean body mass index. They usually lean. We then measure these three things: a mean age of 35 to 60 years, family history positive, and lean patient. If these factors are present, then we measure the glutamic acid decarboxylase and autoantibodies. If along with this the glutamic acid decarboxylase antibodies are also positive, then a diagnosis of LADA is made. Then also we do evaluation of C-peptide and HLA-DRQ typing and measurement of other antibodies, like the insulin, islet cell autoantibodies, thyroid autoantibodies, which may have, because this LADA can have association of other autoimmune disorders like autoimmune thyroiditis, autoimmune diabetes, pancreatitis, etc. So we do the measurement of other autoantibodies also. Also we do evaluation of C-peptide, because there is decreasing level of C-peptide in LADA. Initially there will be presence of C-peptide because there is some amount of insulin secretion, but over as the time progresses, the insulin secretion, it decreases because of destruction of the beta cells, thus leading to decrease in the C-peptide levels. Okay. So by the evaluation of these factors, we can define the risk of progression of LADA towards the insulin dependency. So this was all about the 1.5 diabetes or latent autoimmune diabetes of adults, LADA. To summarize the lecture, I'll be differentiating the type 1 against the type 2 diabetes. So type 1, they usually have an onset less than 30 years of age, more so less than 20 years, but 5 to 10% can be diagnosed more than 30 years also. The type 2 diabetes usually have an onset more than 30 years of age. Type 1 are usually lean, while type 2 are usually obese. More than 80% patients are obese, except for the elderly patients with type 2 diabetes who are lean. Type 1 diabetes usually have requirement of insulin as initial therapy, while type 2 does not require insulin initially. There is propensity of development of diabetic ketoacidosis in type 1, while there is propensity to develop hyperglycemic hyperosmolar coma or hyperglycemic hyperosmotic state in the cases of type 2 diabetes. In type 1 diabetes, there is increased risk of other autoimmune diseases like autoimmune thyroid disease, adrenal insufficiency or Addison's disease, pernicious anemia, celiac disease or vitiligo. These autoimmune diseases can occur along with type 1 diabetes, while the autoimmune diseases, they do not occur in type 2, the type 2 rather have an association with insulin resistance, hypertension, increased cardiovascular diseases, dyslipidemias, and presence with other insulin syndromes like PCOS or overall metabolic syndrome can be there in patients with type 2 diabetes. That's all. Thank you.